Welcome to the Neuroendocrine Cancer UK Q&A session on the subject of gastrointestinal surgery. This series of Q&A sessions has been created as part of the Neuroendocrine Cancer UK Virtual Patient Handbook, which is due to be released in 2023. My name is Beth, and I will be hosting these sessions with various medical experts, covering a range of questions within neuroendocrine cancer care. Although I have worked with Neuroendocrine Cancer UK for a little while now, I'm not a medical professional myself, and so in many ways, I'm learning alongside you, the audience. Some of the questions I'll be asking have been taken directly from the neuroendocrine cancer community, and the focus of these sessions will be on providing useful information and advice in a concise audiovisual format. In this session, Samuel Ford will be answering a range of questions on gastrointestinal surgery. But firstly, let's get to know him a little better.
Thank you very much for inviting me to contribute to the NC UK question and answer session. My name is Sam Ford. I'm a consultant surgeon at the Queen Elizabeth Hospital in Birmingham, and the vast majority of my job is essentially kind of two specialist interests, and one is sarcoma and the other is neuroendocrine tumours, and in particular neuroendocrine tumours that arise from the small bowel. I have a large practice taking out a lot of tumours, and maybe take out 35 to 40 a year. My research background is I have a PhD in molecular biology, and I currently run two PhD programs, one based in the laboratory and the other which is more clinically based. And as part of that, we're putting together a randomized controlled trial looking at the role of surgery for small bowel neuroendocrine tumours in stage 4 disease.
So let's just begin with the basics, really. When we speak about gastrointestinal surgery, which organs are we including? So, for example, HPV surgeon covers liver, but as a gastrointestinal surgeon, would you remove liver metastases if you were already operating on the bowel? And how much crossover is there between those specialties?
Yes, thank you, Beth. The gastrointestinal tract is quite a complicated beast, and essentially starts with the mouth and runs through to the back passage. And it's really a long tube, but kind of attached to the side of that long tube are lots of different organs. And surgery on those organs takes some expertise, and they're quite different in terms of approach to operating. Mm-hmm. And therefore, we need sort of specialist input from time to time. And I have a very close colleague called Bobby Desari, who's a liver surgeon, and sometimes we work together in the same operation, and other times we work sequentially. So I would do an operation, and then maybe Bobby Desari would do an operation several months later. And I would operate on the bowel, so the bowel would include the small bowel and also the large bowel, sometimes the back passage. And I'd also operate on what are called mesenteric nodes. So when the neuroendocrine tumour spreads from the primary tumour within the wall of the bowel, then it can spread to the lymph nodes, and they quite often present as a fairly bulky tumour in their own right. And I would remove those along with the main tumour. Bobby Desari, my liver colleague, would operate on neuroendocrine tumours that arise from the pancreas gland, which is a big gland that sits right at the back of the tummy and is quite a common site to develop neuroendocrine tumours. And as we know, neuroendocrine tumours can spread to the liver quite readily. And if they do, and if those areas of spread are amenable to surgery, then Bobby Desari, as a liver surgeon, would tackle those. And as I say, sometimes we do it simultaneously. So I operate on the small bowel whilst he operates on the liver, or he'll operate on the liver first and I'll operate on the small bowel afterwards. So, and we quite often wait for several months between operations.
Okay, so probably more of a collaboration really than a kind of a, you work together simultaneously, because as you say, there's such a close link really between the small bowel and the liver in that sense.
Yes, exactly. And the reason why we don't always operate together is that we worry about the additive risk of taking out the bowel and also operating on the liver. Okay. So if there were to be any complications of either one of those, then it has an impact on the other. And so therefore it increases the risk of operating quite significantly. and that's why we tend to avoid that scenario happening.
Okay, so actually, kind of related to that point, the next question is, why is there such a common link between bowel primary and liver metastases?
Yes, Beth, that's a fascinating question, and really can be explained quite nicely by anatomy. Mm-hmm. So the bowel and the liver are very closely linked, and essentially the liver is there to metabolize and store the nutrients that are absorbed by the bowel. And part of the way those nutrients actually get to the liver to be processed is through a blood supply called the portal venous system. It's exactly as it sounds, and it transfers venous blood, which is drained from the bowel, which contains nutrients, up to the liver through the portal venous system. And the portal venous system then deposits the nutrients within the liver, and they are metabolized. And so you can imagine if there is a tumor within the wall of the bowel, then those cells from the tumor can get into that same portal system. So they enter the venous blood that drains from the small bowel, and that's transported straight up to the liver, where those little tumor cells have the possibility of taking hold and making it their new home.
Mm. Is this referred to as the gut-liver axis?
Kind of. It's more the portal system.
Okay.
That we refer to it as, yeah.
Okay, yeah. And is that linked just with the small bowel or other parts of the bowel too?
So pretty much all of the GI tract is drained into the liver through the portal system. So that would include the stomach, pancreas gland, and the duodenum, which is the first bit of the small bowel itself, and all of the large bowel. And then you really two parts of the GI tract that are not drained to the portal system are most of the esophagus and right around the lower end of the back passage.
So next up, we're talking a bit more specifically about surgery. So what are some common reasons that remove surgery as a treatment option for neuroendocrine cancer? And I suppose conversely, what criteria makes a patient suitable for surgery? Perhaps you can kind of answer those within one.
Yes. We quite often operate for neuroendocrine tumors that come from the GI tract, and in particular, the small bowel and large bowel origin. And the reason why we operate is that these are extremely slow growing tumors, but they can cause quite significant trouble. So they can cause blockage of the small bowel by slowly pulling in the wall of the bowel itself, or they can cause disruption of the venous drainage of the blood from the bowel. And the reason why they do that is that the venous drainage is very, very low pressure. So it finds it quite difficult to pass through a mesenteric nodal mass that we were talking about earlier, where the tumors spread to the local lymph nodes. Those lymph nodes are very hard, and so they block the venous drainage, but the arterial supply is high pressure, so it can still blast through. They can also cause pain, and so they can constrict the nerves that run to and from the small and large bowel, and that can be a really quite a big issue. And I think the last thing to say is that these tumors can spread through the blood to the liver. They can spread to the lymph nodes, as we were describing, but they can also spread through what is called transcoelomic spread, and essentially that means that tumor cells can shed from the main tumor, and they can seed themselves onto the peritoneal lining of the space where the bowel sits. And those deposits can grow over time, and they themselves can start causing problems with obstruction and pain. So if we can operate to take out the primary tumor and the mesenteric nodal mass without causing too much in the way of problems, then we will do so, because there's clear advantage in doing it. Sometimes we can't operate and remove all of the tumor because the tumor has spread too far up the blood supply to the small bowel. So those nodes, those mesenteric nodes, have gone too high, and it would mean that if we were to remove the tumor, we'd remove too much of the small bowel itself. It's a little bit like a fan. So if you imagine the fan being like this, with the bowel across the top of my fingers, and this, my fingers being the blood supply here, if the tumor is there, then you just take out that bit of bowel. But if the tumor is down here, then we take out all of the blood supply with the tumor around it, so we'd lose all of the length of that small bowel. And so what we don't want to do is swap one problem for another. So we take out too much small bowel, and then our patients have essentially torrential diarrhea and problems with absorbing nutrients, so-called short bowel syndrome.
Okay. So this is kind of related to that, I suppose. So there is also such a thing as debulking surgery, which is more to do with symptoms. Is it kind of relieving symptoms, would you say? Is that correct?
So the term debulking really applies more to the liver.
Okay. Okay.
So I think it's quite an important point to make that, and also relates very well to anatomy, is that these tumors produce hormones. And those hormones are produced in all of the tumor cells. But the tumor cells which are essentially draining, the blood from those tumor cells is draining to the liver is able to deactivate those hormones, so they don't cause trouble. Whereas if the tumor itself is spread to the liver, the hormones that are produced by the cells in the liver, oddly enough, do not pass through the liver. So the venous blood from those metastases does not go through the liver, so they're not deactivated. So they can cause symptoms of flushing, for instance, and problems with blood pressure. Whereas we don't encounter that normally if the tumor has not spread to the liver, because the liver is able to deactivate those hormones. It's kind of fascinating point of anatomy and how it interacts with these tumors. But coming back to your point about debulking, is that if you have particularly large metastases to the liver, they can produce a lot of hormones which are not deactivated. So by operating on the liver to remove the bulk of the tumor, it means that you're likely to improve your patient's symptoms by doing so.
Okay. Yeah, it was kind of a question related to that I wanted to ask next as well, which is, so when you're operating, I believe that there's kind of a margin around the tumor that you will also remove, which is kind of a tissue around the tumor. I just wondered, is there kind of a standard calculation for deciding the size, or is it kind of unique to each case? Just kind of a query that I had.
Yes, it is largely unique, and sometimes these questions are best answered with the aid of a diagram, but essentially it all comes down to the blood supply to and from the bowel where the tumor sits.
Yeah.
And we normally would operate without having to think too hard about it if the primary tumor and the nodal mass are very much more towards the kind of bowel end of the blood supply to the bowel, if that makes sense.
Yeah.
And the further up the tumor is in the blood supply, the more we worry, and the more difficult it is to obtain a really good, clear margin from the side of the tumor to healthy tissue. And so if we've got a good margin or good amount of healthy tissue between the blood supply, the actual vessels itself, and the edge of the tumor, then we can be a lot more liberal and take a good, very clear kind of chunk of or healthy cuff of tissue around the tumor. But if the nodal mass, the lymph nodes, are right hard against the wall of the artery, then we don't have that ability to get really wide clearance of the tumor, because trying to do that then would mean that we'd divide the main artery to the rest of the small bowel, and then the patient would not then survive. So we take it on very much of a kind of pragmatic basis. Yeah. And I think a further point to make on that is that it depends very much on the stage of disease. So if your patient has liver metastases which cannot necessarily be cleared by surgery, then we're much more pragmatic when it comes to taking out the primary tumor and mesenteric nodes. So we take less of a risk, because in theory, then it's difficult to actually cure your patient of the cancer anyway, because they already have significant disease in the liver. But if there is no evidence of disease in the liver, or the disease in the liver can be cured by surgery or removed by surgery, then we would be much more expansive in operating on the primary and the mesenteric nodal disease in order to try and give our patients the best possible chance of being cured.
So if surgery is possible, what is the optimal preparation from a surgical perspective for a patient to follow?
So we spend a lot of time essentially staging the tumour for our patients. So we would do a CT scan of their chest and abdomen and pelvis, which gives us a lot of information about the blood supply to and from where the tumour sits. And also, to a degree, gives us some information about where the tumour has spread, if indeed it has spread. Yeah. We also do an MRI scan of the liver, which gives us very good views of the liver itself and helps us decide whether there's any evidence of spread to the liver. Mm. And we also do a very specialist scan called a DOTA PET scan. And the DOTA scan essentially is a combination of CT, so you get structure, but you also get evidence of function of tumour cells. Mm. So the DOTA itself will stick to the wall of the tumour cells and glows on a Geiger counter. So you can see structure from the CT and function, and you put them together and it tells you where the tumour cells are sat. So it's a very, very useful aid in trying to stage disease so that we can make a plan as to what to do about it. We also do blood tests. So we look for evidence of metabolites from the tumour itself, from the hormones that it's producing in the urine, and also in the blood tests, so-called chromogranins. And they can be used to tell us how active the tumour is, but also can be used as a tool to keep an eye on the patients after surgery to see if there's any subtle evidence of the tumour having come back. Mm-hmm. And from the point of view of our patients, staying fit and healthy, balanced diet, losing weight, gaining muscle mass through exercise prior to surgery, these are the things that are extremely important to try and help get through the operation with minimal problems.
Yeah. So yeah, I was actually going to ask you a bit about the Prepare for Surgery program. Do you kind of follow that? So we mentioned it on the NCUK website. It's an acronym that stands for a few things you just mentioned there as well, which is physical activity, eating well, psychological well-being, removing bad habits. So it's I was kind of researching it. It doesn't seem to maybe be used everywhere, but it's kind of a probably something you follow, but maybe not in such an official kind of, that's what it's called. But do you speak to patients kind of around those things, or do they work with other healthcare professionals like nutritionists or physiotherapists?
Yes, yeah, exactly. So most of our patients have access to nutritional support, which is really very important for patients with neuroendocrine tumours, especially if they're arising from the bowel or the pancreas gland itself, because it's likely that the presence of the tumour will interfere with their ability to absorb nutrients. And so they just need a little bit of help in optimizing how they eat and what they eat in order to maintain a healthy weight and essentially body composition to help healing and help get through the operation.
To post-surgery now, how do you prepare patients post-surgical expectations? So, for example, recovery times?
Yes, that's a good question. And I think before we go on to post-surgery, it's probably best just to mention very briefly, immediately prior to surgery, we will admit our patients to the hospital the night before, which is an unusual thing to do in the kind of modern era of operating, because normally patients will come in the morning of surgery. And we do that in order to start an infusion of a medicine called octreotide, and that medicine is designed to attach to receptors on the tumor cells and essentially make them go to sleep, to try and stop them from producing any hormones during the subsequent operation that may interfere with blood pressure on the operating table. So that infusion runs overnight, and then we do the operation the following morning. Mm-hmm. And then post-operatively, our patients are normally sent to the intensive care unit or a high dependency unit in order that we can keep a very close eye on their blood pressure. Mm-hmm. Because of the potential problems from the neuroendocrine tumor cells themselves. Mm-hmm. And then under very close observation, then we slowly wean the octreotide infusion down over a 24 to 48 hour period. And we know that they're nice and safe as they come off it, and they're very, very, very closely monitored. And then really the post-operative course will follow a fairly kind of standard kind of course after having had bowel surgery. So our patients normally, we start on kind of a liquid diet only. So a little bit of soup, a little bit of build-up drinks, and then slowly progress to more solid food. And that process normally takes about 4 to 5 days. And normally our patients would be in hospital for about 6 nights in total, assuming that there aren't any problems such as chest infection or more serious complications that thankfully we don't see very many of. But those would include things like leakage of the join between the two ends of the bowel when we've taken the tumor out. That's so-called an anastomotic leak. And if you look at papers, they would suggest that the risk of that is around about 5 to 10%, but in reality, it's more like 2%, 1.5%, 2%.
Okay, so it's quite a little bit of an extended time in hospital, and then if further if there is any complications, but generally,
exactly. Yes, our kind of average nights in hospital is around about six nights.
Okay. And then kind of following on from that, how, so you touched on it a little bit, how high are the risks of infections or complications from surgery? So probably not as high as maybe papers say, but.
Yeah, so infective complications are thankfully relatively rare, and even though we're opening the bowel where there's lots of bugs, we tend not to see much in the way of wound infections, because when we open the bowel, we can control the kind of content of it with kind of soft clamps to stop anything coming out.
Okay.
And also we take a lot of care and attention to avoid any contamination of the inside of the tummy and the edges of the wound.
Yeah.
So wound infections themselves, we don't see many of, and maybe the risk of that is around about 2 to 5%, and that certainly could slow healing of the skin. Leakage of the join where we put the two ends of the bowel back together, it can happen, and if it does happen, it is really quite a significant event and can make our patients really quite poorly, and sometimes they need to go back to theatre to have another fairly prolonged operation. And sometimes the ends of the bowel brought out to the surface, albeit temporarily, or it can be managed with antibiotics. Sometimes we need to put a drain through the surface of the skin into a collection of infection inside the tummy, which is done with X-ray guidance, and essentially we take it on a case-by-case basis. And other things that can happen, chest infection, so we encourage our patients to take deep breaths afterwards, and they have something called incentive spirometry that aids keeping the kind of, especially the lower part of the lungs open to reduce the risk of infection getting in. And other things that we think about are blood clots. So blood clots can form in the calf muscles, and those blood clots can go to the chest. And again, we don't see very much of that, but we are extremely kind of vigilant and think a lot about trying to reduce the risk of blood clots. And so patients have what's called intermittent calf compression on the operating table. So we put these little kind of blow up kind of cuffs around the calves, and they compress the calf muscle every 10 minutes or so to make sure the blood is flowing. And our patients have medicines to thin the blood whilst they're in hospital to, again, reduce the risk of any blood clots forming. And perhaps irritating for the patients, but actually good for them, is wearing those TED stockings, which can be quite itchy and difficult, but they too are designed to return blood back up to the heart to try and reduce the risk of blood clots forming.
So we're on to our final question, which I think is quite an interesting one. So it's a bit to do with kind of technology around surgery or techniques. So firstly, can bowel surgery be performed through laparoscopy?
So the answer to that is yes, it can. However, like pretty much all of these questions, really, it is very much a case-by-case basis. And the really important factor here in whether we would offer patients surgery with keyhole or laparoscopic operating versus an open operation is how far down the blood supply the mesenteric nodal disease sits, and how safe or unsafe is it to tackle with keyhole surgery. So if those those lymph nodes are very much close to the tumor and close to the wall of the bowel, then operating with a laparoscopic approach is entirely reasonable.
Mm-hmm.
If there is a risk and a significant risk of encountering bleeding or needing to deal with those blood vessels very, very high up in the blood supply to the bowel, then an open operation is much better. And the reason why we do an open operation is that we can do what's called a Catal-Brash maneuver. And that essentially is a surgical maneuver that we see and do on the battlefield or in trauma surgery. And essentially it involves what's called medial rotation. So we mobilize or loosen the attachments of the colon and the small bowel itself and bring it right up so that it can almost bring the small bowel and the colon right out of the patient's kind of abdomen if you wanted. And the reason we do that is it means that we can actually get the surgeon's hands right around the blood supply, right at where it comes off the aorta, the big artery at the back, in order to feel where those really important blood vessels run. And then you can make a judgment as to how much of the small bowel you can take and whether you can actually clear the mesenteric disease or not. And that assessment is impossible to do laparoscopically, and can be really quite dangerous.
Yeah.
And just to kind of clarify the use of that maneuver in the battlefield is that it also allows us a really good view of the aorta, the big artery at the back, and also the IVC, the inferior vena cava, which sits next to it. And so you get a beautiful view of both of those structures when you do that maneuver.
Interesting. So another form of surgery is robotic surgery. I was kind of reading about this a little bit, and do you see it much? Is it used much within your work, or have you kind of seen developments with that?
Yeah, so at the moment we don't use the robot for neuroendocrine tumor surgery, certainly at the Queen Elizabeth Hospital, although it is coming and it is a technology that we plan to embrace. But the use of the robot would still very much really be limited to the more straightforward operations, and at least for the foreseeable future, not really employed for those really difficult operations where there's very difficult decision making and danger involved in operating.
Okay, and it's beneficial in the sense that it can do very small, precise incisions and.
The benefit of the benefit of the robot really is that you can articulate, which sounds rather odd, but with keyhole operating, the instruments can go essentially in and out in a straight line, and they can rotate through 360 degrees. But that essentially is the extent of maneuverability, and the view that you get is two-dimensional, so you don't really have any depth perception with laparoscopic operating, whereas the robot gives you three-dimensional views, so you get depth perception, and you can also articulate the robot wrist. So it means that instead of just going in and out and twizzling around through 360 degrees, you can actually kind of bend the end of the instruments, and it works a lot more like the surgeon's hand would do in open operating. So that essentially is the benefit of robotic surgery. It just more closely mimics open operating, but one of the drawbacks is that the surgeon's hand and kind of operating kind of experience comes from feeling the tissues, and essentially you miss out on that because you don't have any feedback on how the tissue feels, where is the edge of the tumor, which you can feel with your hands, and also just no real clear ability to judge with a robot how much pressure is being put on the tissues. And the kind of skill of the surgeon as such is about gaining tension in the tissue and having the right amount of tension, which then allows you to see where you need to go with your incision and your operation. And if you can't reproduce that, it either pulls too hard and things bleed, or it's not pulled hard enough, and it's very difficult then to see where you need to proceed to make the operation move forward.
I can imagine that. So it's kind of it it's being used as a tool. It's not obviously it's not a replacement. It's a kind of a thing that can be utilized in certain ways, and it's got its benefits, pros and cons. So in terms of developments in general in surgery, gastrointestinal surgery, are there any of note that are kind of worth mentioning?
I think you've touched on the main one, which is robotic, but I think the other really important kind of move forward for the management of patients with neuroendocrine tumors is centralization of care. So over the last 10 years, there's moved on hugely. So we've developed special centers where surgeons have a special interest in operating on neuroendocrine tumors. And given that they're relatively rare, if all of the surgeons that ever saw a neuroendocrine patient had a go at operating on them, then maybe they'd do 1 or 2 operations every kind of 3 to 4 years, whereas I do an operation on the neuroendocrine tumors pretty much every week. And so we get used to kind of judging how much of an operation would be involved with taking out the tumor, where the blood supply runs in relation to the tumor. Can we clear it? Can we not clear it? And also we have all of the backing from our specialist team. So my anaesthetist is extremely good and used to dealing with neuroendocrine tumors and the problems that can arise from their hormones. And our team on the intensive care unit is also very, very experienced in dealing with complications from the hormones themselves and weaning the octreotide infusion. And so essentially we improve outcomes from surgery by becoming simply more familiar with doing it.
Yeah, and having that kind of specialist knowledge across the board of your team. Yeah. Thank you, Sam, so much for joining me today for this Q&A session. It was really interesting. I think we kind of touched upon quite a few different topics within surgery. And for those watching, I hope that this video on gastrointestinal surgery has been useful for you. For those interested, this Q&A session is part of a series where I speak to various medical experts covering a range of questions within neuroendocrine cancer care. So keep an eye out for those. And thank you again, Sam.
Thank you, Beth.